Welcome to the Clinical Education channel. I'm Salah Abbas. I'm a Associate Professor of Surgery at Deakin University in Victoria, Australia. Today's lesson is about achalasia or achalasia of the cardia as it's more known. We will start with the pathophysiology of this condition. So the name achalasia means it's the failure of relaxation, and here it's failure of relaxation of the lower esophageal sphincter. This happened as a result of degenerative changes in the myenteric plexus, which sits between the circular and the longitudinal layers of muscles in the esophageal wall. The disease seemed to start with the myenteric plexus of the lower esophageal sphincter, and then it will progress with time to involve the muscular wall of the esophagus. As far as the cause of this condition, it's more or less idiopathic. Can happen for unknown reasons. There might be some genetic elements, but patients who had drastic weight reduction by a variety of means, it has been reported that they could get this condition. In general, it is a rare occurrence, though. It is known in South America to be caused by a trypanosoma cruzi, which is a parasitic infection that lead to what is called the Chagas disease. And part of that picture is degeneration of the myenteric plexus of the esophagus and lower esophageal sphincter. Eventually, there will be a loss of progressive peristalsis of the esophagus as the disease progresses. And in long-standing cases, it could lead to what's called the mega esophagus. It's also known that long-standing cases that are untreated or unfollowed up, it is a pre-malignant condition with a high risk of having cancer of the esophagus. The degenerative process in this condition seemed to start with the lower esophageal sphincter, and in particular the inhibitory neurons of the plexus. These neurons are known to be responsible for relaxation of the lower esophageal sphincter in response to the swallowing process. And they typically produce either nitrous oxide or vasoactive intestinal peptide, as opposed to the excitatory acetylcholine nerve endings and fibers that stimulates the contraction to keep the resting pressure in the lower esophageal sphincter. However, with the progress of the disease, it will involve also the excitatory motor neurons, and that will lead to, that's why patients will get loss of peristaltic activity in the body of the esophagus. Clinically, these patients will present with progressive dysphagia. So it will start usually with liquids and then progresses to solids. They would have significant regurgitation of undigested food, and they could have silent aspiration with respiratory symptoms. There will be a significant weight loss associated with it as a result of malnutrition. As we mentioned in a previous lecture, that when a patient comes with dysphagia, the first lines of investigation are going to be an endoscopy, and that will be followed by either barium study or CT with oral contrast. On endoscopy, the esophagus will be remarkably dilated in these patients due to failure of peristalsis. There will be food residue, There might be some candida infection in on the mucosa of the esophagus, and there could be erosions and chronic inflammatory changes. It's often also possible to notice congested upper airways as a result of the ongoing regurgitation and the aspiration process. The second line of investigation, once we have done an endoscopy, we will need to get a barium study for them. And the barium is helpful to show us the extent of the esophageal dilatation, also the state of the peristalsis in the muscles of the esophagus. Typically, the barium study will show, in addition to that, delayed passage of the contrast from the esophagus into the stomach related to spastic contraction and failure of relaxation of the lower esophageal sphincter. And eventually, when the contrast passes through, it will be in a very peculiar manner, which is called the rat tail or the bird beak's appearance of the lower part of the esophagus. Also, on plain abdominal X-ray, it's notable that there is no air bubble or the gastric air bubble that you see on a plain abdominal X-ray due to the inability of the patient to adequately swallow air and clear the esophagus from the swallowed air and saliva. Now, the cornerstone and the definite diagnosis will be obtained by performing esophageal manometry. And what the manometry does, it will look at the peristalsis of the esophagus. It will show us the resting tone of the lower esophageal sphincter and further details. In patients with achalasia, there will be two changes in the on the manometry of the lower esophageal sphincter and three changes in the muscles of the esophagus. With the lower sphincter, there will be hypertensive contractions, and the resting pressure is typically more than 35 millimeter mercury. And the second point is that while normally the lower esophageal sphincter relaxes in response to the swallowing process, it will fail to relax after swallowing. The changes that will be typically seen in the esophagus is the high intraluminal pressure and also the presence of ineffectual contractions that will lead to no peristalsis. The third one is the manometry will see also low amplitude waveform contractions that again are sporadic and discoordinated. And in here, this shows us the typical manometry of the esophageal wall and lower esophageal sphincter. And in here we have the typical pattern of achalasia with a hypertensive lower sphincter and also the low amplitude and the ineffectual contractions of mainly the middle and lower part of the esophagus. Now we discuss the management of the achalasia. So the management can rest from medical to surgical measures, but Hiller's mytomy, which is done laparoscopically, usually successfully, is the gold standard for the surgical treatment and for the treatment in general for achalasia of the cardiac. There is a new endoscopic procedure which is called peroral endoscopic myomectomy, and that's done endoscopically by making an incision in the mucosa of the esophagus and making a tunnel between the muscle wall and the mucosa to divide the lower esophageal sphincter. In the end, the endoscopist will close the mucosal defect. It's highly technical and needs a lot of experience to be able to achieve good results. In terms of medications, Often, patient will have some benefit from either calcium channel blockers or GTN that will help to relax the smooth muscles. But these are palliative measures, and they are not used in young people who are fit for surgical intervention. Botox has been tried, but the recurrence rate is 50% of the patients will have recurrence within 6 months, and it's almost certainly they will have failure and recurrence in the long term. Dilatation is a common form of management of the disease as well. It will need to be repeated. It can be done in the form of pneumatic pressured dilatation, where the endoscopist will pass a balloon down the esophagus, and that get inflated up to what's equivalent to 54 French rigid or flexible, rather, bougies. Very occasionally, patients will present with extremely dilated esophagus, basically esophageal failure, where there is no effective treatment other than resection of the esophagus, and in that situation, the entire esophagus will be resected and replaced by the stomach or a colonic conduit by an experienced esophageal surgeon. You will find that most of these patients who present with achalasia are relatively young patients, and these patients should be managed aggressively, preferably with surgery and long-term follow-up. There is no set specific regime for following them up endoscopically as a surveillance for cancer, but it will need to be done on frequent occasions. And non-operative measures will usually be offered to patients who are not willing to have surgery or have comorbidities that would prohibit surgery. Thank you very much. Please subscribe to our channel. Leave us your comments so we can interact with you and answer your questions.